You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we're joined by Dr. Thomas Keane, the National Coordinator for Health IT. Host Tony Schueth, CEO of Point of Care Partners, and co-hosts Alix Goss, Senior Consultant and Program Manager of the HL7 Da Vinci Project, and Janice Reese, Senior Consultant and Program Manager of the HL7 Fire at Scale Task Force, talk with Dr. Keane about interoperability as critical infrastructure, progress on prior authorization automation, and the ongoing challenges with price transparency. They also explore the growing role of artificial intelligence in making health data more usable, and what stronger enforcement around information blocking means for the industry moving forward. We hope you find this episode enlightening. If you have suggestions for future episodes, send us your idea by visiting the podcast page at pocp.com under the Insights section and share your thoughts by submitting a form.
Welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners and your host for today's episode. On this show, we serve up fresh perspectives and candid conversations on the challenges and opportunities shaping health IT. Today's episode is a fun one because ONC is ONC again. After a brief rebrand to ASTP, we're back to the acronym everyone knows and loves. It's a shorter one for the health IT alphabet soup. Today, we're joined by Dr. Thomas Keane, who brings a uniquely broad perspective to health IT policy from engineering to clinical care to federal leadership. We'll explore interoperability as infrastructure, the push toward automation and prior authorization, the realities of price transparency, and the growing role of AI in all of it, among other side roads we might take. Joining me today are two people who spend a lot of time in the weeds of this stuff making it work. Alix Goss, Program Manager for the HL7 Da Vinci Project, and Janice Reese, Program Manager for the HL7 Fire at Scale Task Force. Alix, Janice, thanks for joining us. Let's start with quick introductions. Janice, why don't you get us started?
Thank you so much, Tony. I appreciate the opportunity to be here, and thank you, Tom, for joining us. I'm Janice Reese, the Program Manager for HL7's Fire at Scale Task Force, or FAST, and also a Senior Consultant with Point of Care Partners. My work sits at the intersection of interoperability, policy, and implementation, bringing together stakeholders across HL7, CMS, and the broader industry to help scale fire in a way that's practical and trusted. At FAST, I focus on advancing the foundational pieces across identity, security, consent, directory, and testing at scale, so we can enable more seamless, secure data exchange and ultimately support better outcomes for patients and providers.
Alix.
Thanks, Tony. It's great to be here with all of you. Today's podcast certainly touches upon work I've been involved with in a variety of ways and capacities, and I'm grateful to see the progress that's being made. Such as infrastructure, foundational to the fire forward future, is an area I worked on at FAST when it was at an ONC task force during Rutgers time, and then I supported the directory and consent use cases development work in the HL7 FAST accelerator that Janice now leads. For prior authorization, I serve as the program manager for the Da Vinci Project and have been with the project since 2018. Da Vinci's burden reduction IGs focus on prior authorization to create a modern paradigm spanning clinical and administrative workflows using FHIR and the APIs. Prior authorization has been an industry pain point for a long time, and I've seen this firsthand, including during my two-term NCVHS tenure where I performed a retrospective with the team on the review of HIPAA and also prior authorization as the primary use case during ONC's HITAC task force on the intersection of clinical and administrative data, which I co-chaired. But as a senior consultant with Point of Care Partners, I have been in this field for more than 35 years, bringing my personal passion to strengthen organizations, public policy, and national standards to achieve healthier and more productive people. And this includes working in developing national standards in the policy realm, as well as the EDI and the fire communities, informed by boots on the ground work implementing and complying with federal and state regs, while aligning to business strategies, systems integration, and operations management in both public and private sectors. To round out my work on Da Vinci and my other client efforts, I serve as the chair of HL7 International's Policy Advisory Committee, and I'm also HL7's liaison and currently the chair of the Designated Standards Maintenance Organizations, just because we need more acronyms, the DISMO, established under HIPAA to maintain and update the technical standards for electronic healthcare transactions adopted under HIPAA by HHS.
Thanks, Janice and Alix. And, it's our pleasure to support both DaVinci and FAST. Dr. Keane, welcome to the podcast. I'd like to talk to you about your journey that got you here. Your background is often described as a unicorn in federal leadership. You started as a software engineer, became an interventionalist radiologist, and now lead national health IT policy. What sparked those transitions, and what ultimately convinced you that you could have more impact in policy than in clinical practice, although you still practice even now, right?
That's right. Thanks for the question, Tony, and thanks for having me here. And Janice and Alix have really enjoyed collaborating and really glad that you're here to be a part of the discussion today. So I went off to college to become an engineer and majored in engineering. And while in college, I took a job at a dorm at the University of Illinois taking care of handicapped people. And you would have 10 undergraduate aides taking care of 20 disabled students. And I really enjoyed the experience. And the other 9 people who worked there all went on to become physicians. That wasn't in my work planning at the time, but I kept in the back of my mind that this is something I might want to do. So I went out and I worked a couple of years as an engineer. And then when my medical college admission test scores were going to expire 5 years later, I applied to medical school and practiced medicine for a number of years. And while I was practicing medicine, I got involved in the policy aspect of medical practice. And then in 2018, after about a decade of full-time practice, I switched my practice to part-time and started doing federal policy work. I came into the federal government and served for 5 years, and then had the privilege of being invited back to lead an agency that I was at. And so really it was just a matter of interest and experience. You get exposed to something, you say this is interesting, and you build your career around it.
We've had a number of national coordinators that have been physicians, that are physicians, but none that still practice. So that's really, that's really compelling and really must add to your, what you bring to the table from a policy perspective.
Well, that's what I said in the job interview. The reality is I really like practicing medicine. The job of practicing medicine is you take care of sick people. And it's something I still enjoy. And it's also something that I think they'll let me do, that I intend to do until they tell me I can't do it anymore, until I drop dead. So I still enjoy the work. And, I had 2 mentors, a number of mentors, but 2 of them. One was a fellow named John Cameron, who practiced surgery until he was 80 years old. And my radiology mentor was a fellow named Alix Margulis, who practiced medicine until he was 92 years old. He and I published a paper together when he was 91 years old. Yeah, and he lived to be 97.
That's amazing.
So it's a great field and one that I still enjoy.
And we have a few more years of you is what I think you're saying. So let's switch. Let's switch gears a little bit. You've described interoperability as needing to function at the speed of trust with expectations closer to consumer apps. As we push toward API-driven exchange, how are you thinking about balancing that vision with the reality that many organizations are still reliant on legacy approaches? Also, the CMS Health Ecosystem First Wave Launch Live event was just held yesterday, April 9th. Maybe include any relevant highlights you might, have in mind, and because many of our listeners may not have been able to tune in.
Sure. So CMS, under the vision of Secretary Kennedy, Dr. Oz, and Amy Gleason, who are running the CMS Health Tech Ecosystem Initiative, the vision is to use the government's convening power and collaboration power to advance technology and advance technology solutions quickly, where there has to be an intersection between the tech solution and the government. And I think they've been doing an extraordinary job. they did a market landscape analysis, and they said, where are the pain points and where would we like to see the market move? And they asked people, given the broad landscape of potentials, who wants to join, who wants to pledge, who wants to meet certain pledge requirements, and who wants to collaborate with us to advance the health tech ecosystem. And the pledges included doing work on technical background stuff, like putting together a provider directory or putting together patient matching algorithms, and patient-facing, more public-facing stuff like conversational AI assistance. And as we saw at the rollout of the minimum viable products yesterday, there have been some absolutely extraordinary advancements just in the 9 or 10 months that this has been going on. And it really shows the power of the government's ability to convene stakeholders. And we found that everybody in the market really wants to advance, and we've found that people are able to collaborate when they're given the opportunity. As far as ONC goes, we're taking a more traditional approach in addition to using the convening powers of government. So we're looking at regulation, we're looking at promulgating standards, we're looking at doing everything we can to make sure that information exchange happens. So as you know, in our HTI 5 rule, we've proposed to refocus the health IT certification program from the legacy standards and functionalities that have always been supported to a new FHIR-based API approach where we focus on regulating interoperability. Now, we do not expect the legacy standards to disappear. We expect, because the market demands it and because it is so built into the system, that they will continue to be supported. And you can see this in the way that we administer the TEFCA network. TEFCA is based around the IHE standard, which is, as you know, is a legacy standard, and based around V3 document exchange, HL7 document exchange. We're also obviously implementing the ability to find and utilize FHIR endpoints. We're trying to incorporate the most advanced technology into TEFCA, but TEFCA continues to support legacy technologies because we understand that you have to meet the market where it is. Mm-hmm. What the deregulation does is, because we lower the standards I shouldn't say lower the standards, we decrease the burden of entering the market. We hope that many point solutions and that many solutions that would not otherwise be available in the market will become available in the market, because the high cost of certification will come down. We don't expect the functionality to go away. We expect it to be easier for folks to develop solutions that work for particular segments and sectors of the market. And to be concrete, we were approached by organizations that focus on serving the underserved. And they told us, you know, the solutions in the market for EHRs are really beyond our ability to afford and beyond our ability to maintain. You not only have to purchase and maintain the system, you also have to be able to source technical and IT help to be able to maintain it day to day. And they said that's not really within our purview. But there have been new entrants to the market, and these provide robust and oftentimes lower cost and lower maintenance solutions that still perform all of the necessary functions. So we linked these folks up, and it appears that they've got a solution that's going to work for them. So that's the direction that we're hoping our pivot towards interoperability and our pivot towards the more advanced standards is going. We don't lose the legacy, but we allow for more robust solutions to enter the market.
By the way, we're hearing the same thing, because one of the other initiatives, HL7 FHIR initiatives that we program manage, is Gravity. So we didn't have our program manager on today. Can't have everybody, but we're hearing the same thing. Janice, from a FAST perspective, what are the biggest infrastructure gaps that still need to be addressed to make this vision real at scale?
Yeah, thank you, Tony. From the FAST perspective, the biggest gaps aren't in the FHIR APIs themselves. They're in the trust infrastructure. that make those APIs usable at scale across organizations. And I would echo what Tom said, is that I attended the virtual event yesterday, and there's definitely tremendous amounts of progress and success in the connectivity of what's been happening. And FAST has been participating in those various work groups across the health tech ecosystem and the work that Amy Gleason has been leading. But I think first, identity still remains a foundational challenge. We're about to launch the next work for FAST Identity STU3, because we don't yet have a consistent federated approach to verifying and asserting who patients, providers, and organizations are across networks. And without that, everything downstream, access, consent, attribution becomes fragmented. So I know that the Identity Working Group has been working on common data standards across a variety of the CSPs that CMS is contracted with. And so we're incorporating that and working closely with the Karen Alliance on our next version of FAST Identity to incorporate their digital trust framework and really support where the industry is headed and where CMS is going, especially with the health tech ecosystem. Second is security and trust frameworks. While we have strong building blocks with what we are doing with FAST security and OAuth and profiles, adoption is still uneven because there still needs to be a lot of education. So having a consistent policy-aligned approach so that organizations can trust each other's credentials and exchange data without bespoke integrations. And that's a lot of education we still need to do. And at the same time that we're working on FAST Identity STU3, we're also working on FAST security, because those two are very much connected. And we're training, kind of educating people on the vocabulary around authentication, authorization, and how that works into all the apps and the flow that we saw yesterday with the health tech ecosystem. The third is consent and patient preferences. And I just presented to the patient preferences working group under the CMS health tech ecosystem. Today, consent is still siloed and it's not computable across systems, but again, a lot of education. So to truly support patient-directed access and data sharing, we need standardized interoperable ways to capture, discover, and enforce consent across networks. So we've been presenting to the NCPDP group and others that are working on consent, again, educating on what we're doing. We're about to publish the consent IG in May after very successful work. And then finally, discovery and endpoint directory and endpoint discovery. We've been working closely with Fred and all of the work there, because there's no universally adopted way to reliably find who is where and how to connect across the ecosystem. So without that scalable national directory approach, interoperability remains point to point. And I think there's been a lot of progress in the work that we've been supporting CMS in that area. So at FAST, we're focused on closing these gaps by aligning policy and technical implementation so that identity, security, consent, and directory work together, because we're a cohesive trust layer and we're educating people on that trust infrastructure. And I think that ultimately enables FHIR to operate a network and national scale, not just individual implementation.
Thanks, Janice, for that background. Let's pivot a little bit to an area of your expertise and passion, Dr. Keane. You've often said that behind every image is a patient waiting for answers. Yet we're still largely a sneakernet industry where patients hand carry CDs between offices. Your recent diagnostic imaging RFI suggests that the barrier isn't a lack of standards, since digital imaging and communications in medicine DICOM and DICOM Web exist, but rather a lack of incentives and certification for the vendors themselves. As you look toward future rulemaking, do you believe we need lightweight certification programs systematically for imaging systems separate from EHRs to force the move away from physical media and toward a national exchange framework like TEFCA?
Well, that's why we put out the RFI. We wanted to say to the market, building on the theme that we had just talked about, meeting the market where it is, where are you, where are the gaps, and how can we help? As you know, hospitals and physician workflow are inhibited by the inability to get imaging, which is oftentimes key to diagnosis and key to understanding what's going on with the patient. And so we wanted to ask the market what's going on. I will tell you a story about imaging exchange from my days working as a radiologist. I took a class in operations management, and one of the things they teach you is that the most efficient way to service demand is with a single queue and multiple servers. This is why, other than McDonald's, when you go into a restaurant, a quick serve restaurant, they have a single line and multiple servers. This approach prevents what they call blocking and starving, where either one line doesn't have anybody in it or another line is blocked, going wrong with the transaction. So I brought this back to my radiology group, where we were covering, I think, 6 hospitals and 3 imaging centers. And I said, you know, if we have a single unified work list, if we actually get a Cloud Paks vendor and have a single unified work list, it's likely that we will get through the work more quickly. And there was a certain outlay of cost to be able to do this, but we essentially implemented our own image exchange network. We scooped up the images from each of the hospitals and imaging centers we worked for. We put them on a single work list and we read off of that. And I believe it was, we didn't store the images. We just scooped them up and read them. So it was $1 for each image. And, you know, that can be costly. But what we found is that we were able to service the demand much more quickly, and everybody was going home earlier in the day. And so it was a victory. We see the same thing as potential if images actually get exchanged electronically rather than being exchanged by disks. And there are many barriers. As you talked about, there is a lack of economic incentives. Despite the fact that there is a DICOM standard, DICOM is like Unix. There are standards, but all of the standards are not necessarily conformant and interoperable. And there's also economic incentives, I'm sad to say, to not transfer imaging, but rather to reproduce it. While the individual frontline physicians and people working in the radiology department don't like reproducing imaging, there is an economic incentive. You get a little bit more money if you have to rescan a patient. So we're hearing about all of these in our RFI, and we expect in future rulemaking, both with us and CMS, that we will be able to address some of these, and we will be able to address some of the standards gaps. So stay tuned.
Well, we're looking forward to that. And I assume that McDonald's is responding to the RFI. You did bring up McDonald's. And for the record, I think it's the first time we've had McDonald's mentioned on a Dish on Health IT podcast.
The reason they still maintain their storefronts with multiple lines is because I guess it's part of their branding. They're aware that it's less efficient, but it's what people expect.
You know, it's the Dish. I'm getting hungry. I know where I'm going for lunch today. Let's pivot to prior authorization in CMS 0057. Prior authorization remains one of the biggest sources of friction in healthcare. With CMS 0057 and Da Vinci use cases gaining traction, we're seeing progress on the medical side, but pharmacy prior authorization remains fragmented. How is ONC thinking about bridging that gap so that clinicians understand requirements in real time, regardless of benefit type?
Well, as you guys know, last summer we passed our HTI-4 rule, and I would like to apologize in advance that we don't give our rules cool names, we just number them. The HTI-4 rule, we finalized the Da Vinci standards for medical prior authorization, but also the standard for real-time prescription benefit, the NCPDP standard for real-time prescription benefit and prior authorization. Now, unfortunately, simply promulgating a standard doesn't mean that it's actually going to work in the market. So what we're doing is actually working with the vendors, the EHR vendors, the PBMs, and the various intermediaries who handle prior authorization and different aspects of the value chain in prior authorization and pharmacy benefit determination, to make sure that the information is robust, that it's complete, that it's interoperable, and that it actually lands robustly. Just to give one example, the real-time prescription benefit information, even though it's available on many EHRs now, it's not always leveraged by physicians. And we asked why, and it's because sometimes the information is incomplete. Sometimes the information is outdated, and when people actually process, the D.0 telecom B1 transaction claim standard, that they get a different piece of information than they got on the RTPB standard. And so we're working with the industry to try to close these gaps. It's not enough to throw a standard over the wall and hope everything works out. And so we're engaging with the market to make sure that this fragmentation eventually becomes coordination.
And in the RTBC request, you can also include a diagnosis code. So there's a field for it, but it's not mandatory. And so if included in that request is that diagnosis code, theoretically a PBM could do some initial analysis to help determine if prior authorization is really required. So it's
correct.
It's promising, and if we start to get physicians, providers using RTBC, that's a good thing and a step in the right direction.
What we're most excited about is this is part of the Secretary's vision of price transparency, and the RTPB standard allows folks to at least see what is on formulary, what is not, what would require prior authorization of multiple therapeutically equivalent alternatives. And this means that at the time of prescribing, the doctor and patient can work out together what's not only the most therapeutically efficacious solution or drug, but also what optimizes for patient cost and their benefit plan. And we really feel that this will be revolutionary. We know that for routine medicines, people save on average $72 per month per prescription. And for specialty medicines, they save about $800 per month when the functionality is actually exercised. So we're very excited to get this rolled out in the market.
And you get the results back at the patient level rather than at the group level. And I know we're getting into
Correct.
the weeds here, although our audience, does know health IT, but we're getting those results back at the patient level, which is exciting.
But Tony, I think you also just got an idea for the next podcast that maybe you can take the RTBC for the real-time benefit check and marry that up with DaVinci priced patient cost transparency and talk about how that transformation really supports that paradigm of that patient provider interactions with the right data at the right time for joint decision making and with more visibility into financial liability, because that is really, a pain point, a stress point for patients. And when you're stressed, you're not healing as well.
Absolutely. Alix, since you jumped in, and I appreciate that, why don't you give us an update on where patient cross transparency is within DaVinci?
Well, Vanessa Candelora, who's also on the Point of Care Partners team, is our subject matter expert, and she's leading that work within DaVinci. They are doing an amazing job advancing their standard for trial use through their piloting efforts. We have a specific project scope of implementers working together because we go in the development process, we not only work with industry to craft the specifications, those business requirements that need to be transformed into software code, but also to think about the workflows that are enabled by that software code. And then we take that through a series of testing efforts through connectathons. But then DaVinci also has been leaning into piloting work, which is much more focused, deeper sort of testing with a production path in mind. And so they've been working with a handful of folks to actually take the next step with the piloting and did a lot of presentations at HIMSS about it. You can check it out on HIMSS TV. And you can also find out some more information on this on our Confluent site, as there's a lot of not only some recordings related to an overview that we did earlier this year on our community roundtable, but also you can get engaged in the meetings and the discussions. And this, I think, is really indicative of it takes a village, and some of Tom's comments about meeting the market where it's at, figuring out how to get the right tech involved, but then also align it with the incentives and business strategies. And so Vanessa's also been coordinating with federal partners that are working on that tri-agency anticipated regulation to really help the market understand what the opportunities are and how to get that good faith estimate and advanced explanation of benefits to fulfill the No Surprises Act. And that's kind of a next wave generation, I think, opportunity for a fired forward future.
Exciting. Tom, how do we move from the check the box compliance to delivering meaningful, real-time, patient-friendly cost information?
I believe my colleagues at CMS are working on this. As you know, they're continuously updating their price transparency rules, and now they're requiring, I believe, the 835 transactions, the actual remittances. Unfortunately, the information is still pretty complicated and difficult for patients to understand. and oftentimes doesn't apply to a particular patient. So we're constantly looking at how we can make this information more accessible and usable to patients, and to allow patients to essentially shop as part of their determination of where they're going to receive care. It's an ongoing process, and we learn from every iteration of the regulations and standards that get promulgated. I know my colleagues at CMS are looking deeply into this and moving forward on it as best they can.
And they certainly are. Let's pivot to AI. Tom, I remember at the ASTP annual meeting, you made a joke and you said that AI is either going to transform healthcare or it's going to boil it down to 3 bullet points on a PowerPoint slide. Love that joke. But building on that, do you see AI as a key enabler for making complex healthcare data usable? Could we get to a point where AI tools translate raw data into personalized, understandable insights for patients and clinicians, including clinical summaries, as well as the price estimates we're talking about?
100%. The development of the large language models has been truly revolutionary. I think most of us, when we first used them, said, wow, this is truly new technology, something we hadn't seen before. I can tell you of a number of use cases that already exist in medicine that do exactly that, where they take complex data and boil it down into usable information. We've been using AI in radiology for 20 years. And whenever I read a stroke scan or a mammogram, I use tools that will actually annotate the very complex images and tell me to look at particular areas of the image and give me an interpretation of the image. When you interpret a mammogram, the 3 findings on a screening mammogram that indicate a patient may have cancer are mass calcifications and architectural distortion. And it can highlight each of these findings to have me take a close look at it. When I read stroke scans, it can actually color in on the CT in real time areas of the patient's brain where there may be lower blood flow, indicating stroke. So certainly in diagnostic imaging, it's been around for a long time. My colleague Amy Gleason over at CMS has talked about how she uploaded her daughter's health records into a chatbot. And her daughter has, she talks about it, juvenile dermatomyositis, a rare disease. And they like to get her involved in clinical trials and to give her the most cutting edge care. So they uploaded, reams of data that she's acquired over the years in the healthcare system to a chatbot. And the chatbot was able to make 2 conclusions. The first is that maybe she didn't have ulcerative colitis. Maybe she had, I believe, eosinophilic colitis, which would make her eligible for more trials. And it also identified clinical trials that she could be involved in. And this was just using one of the readily available chatbots. And as we know, insurance companies have piloted AI health assistants where people are engaged with their care and can be monitored remotely and be given information on their phone about how to take better care of themselves or how to respond to changes in their physiology. All of this is very complex information that gets boiled down to simple decision-making, both for the patient and clinician. Even in radiology, there are now AI assistants that will read your report and write your impression for you so that you don't have to write it yourself. All of the information is already in the report, and it will pull it into an impression. And the advantage of that is sometimes if you spend 10 minutes reading a radiologic image, you forget what to put in the summary, the conclusion, the impression, and AI can do that for us. The tooling is extraordinary, and it's being rolled out in medicine rapidly. Our goal is to make sure that it's secure, reliable, trustworthy, and that it's adopted appropriately.
And to that point, Alix and Janice, what work is needed on data quality, governance, and standardization to make that kind of AI-driven future viable? Alix, why don't you lead us off?
Well, I definitely think you're going to need to have standards in the sense of not only how we capture the data, where we store the data, and how we exchange the data, but also standards in the sense of more like best practices and workflow considerations for the tools that we use for capturing that data so that those LLMs can be well informed and have the structure that they need. We also, I think, are going to need rules of the road to engender trust, as Tom noted earlier. The speed of progress is achieved at trust, and the village really needs to have a lot of trust. And this is a really new era. We're coming into a very powerful era, and the reliability of the data that we're going to be using needs to have some level of accountability and some common understanding of how we interact and treat and work with that data and protect it. So I think that this will impact, how patients actually, interact with the data as well as the clinicians and the professionals that are supporting care outcomes. And I think this needs to have a fair amount of community engagement. I heard Janice talking earlier about language and workforce development and knowledge. And I think there's a whole new wave of helping people get educated so that they can actually interface appropriately. And some of the stuff that we're doing really will become under the covers, and that makes the issue of trust even that much harder, because the big black box does not really speak to transparency, which really fosters that trust that we need. But Janice, maybe you want to add into that.
Yeah, I think from a FAST perspective, there are three foundational areas we have to get right. And it was already been mentioned, data quality and consistency. If data is incomplete or inconsistent or poorly normalized across the systems, AI is going to amplify those gaps. So I think we need stronger adherence to implementation guides, tighter conformance testing, better alignment on how data is represented, especially across clinical and administrative domains. I think that will allow patients to feel a little more comfortable in decisions that might be made where AI is utilized. And then second, the big aspect of what we're seeing is governance and trust. AI introduces new questions around provenance, accountability, and appropriate use. We need the clear governance framework so we know where data comes from, what consent applies, and whether it's appropriate to use for a given purpose. And that ties directly into the work that FAST is doing on consent. And then third, it's standardization at scale. FHIR gives us the structure, but we still need consistent implementation across networks. And that includes identity to know who the data is about, security to ensure it's trusted, directory to find it, and consent to use it appropriately. Without that coordinated layer, AI remains siloed just like the data is today. So I think, yes, AI can absolutely, and I've used my own aspects of health inside as well, Tom, and gotten some interesting contacts for, the vitamins I take or things like that. But I think it helps make healthcare data usable and even intuitive. But the real unlock is pairing AI with a trusted, standardized, and interoperability data foundation. And I think that's what we're all working towards, because that's the work we're focused on with FAST for infrastructure. And without that, it's hard to scale AI in a safe, I think, or meaningful way.
Absolutely. And, Dr. Keane or Tom, Amy was on, our podcast as well and told us the similar story, or the story that you told us. And she also said that once they got that result, they went and spoke to their physician. So there's a human in the loop sort of component of all this. That said, there's a well-documented tendency for humans to overtrust automated systems when they perform well most of the time. How should policy address bias in clinical decision support? And where should accountability sit when AI-driven recommendations influence care decisions?
Well, at least right now, accountability still lies with the physician. As any physician will tell you, you pay a lot for your malpractice insurance, and if you've been in practice for any length of time, you've probably at least gotten some inquiry from a lawyer, or worried about if an outcome crossed the line into an area of malpractice. So the liability still lies with the physician, and I think physicians are acutely aware of this. Physicians are educated to the different biases that occur in diagnosing and treating patients. Anchoring bias is a real thing. If a patient is transferred into your hospital with a diagnosis of appendicitis, you have to really reevaluate the patient from beginning to end to make sure that something isn't being missed. In radiology, we have a phrase called satisfaction of search. This is where you find an initial finding that explains the patient's diagnosis, but you miss an even more relevant secondary finding because you've been satisfied by your search. So you don't want to diagnose the patient's appendicitis, but miss the colon cancer that's lying just adjacent to it. So we're educated to these biases, and it's really incumbent upon the physician to make sure that they don't fall victim to it. I can tell you, when there's a human in the loop, for the most part, we take seriously the responsibility we have to evaluate the patient independently. So when I read mammograms, I actually do the interpretation first, and then I press the little button that puts the annotations on the mammogram, and I say, is there something that I have missed? Similarly, the software that helps identify strokes doesn't work all the time. It'll sometimes say that the patient is having a stroke when they don't, or it'll sometimes miss a stroke. And we are acutely aware that we really have to put our eyes on. It can make us more efficient. It can make us more accurate. But ultimately, I think at this point, both because of the liability system that exists in the United States and because of our education, we understand that we cannot overly rely on tooling. That's even true in the medical device realm. It's not unusual for you to have experience with a medical device and understand that there's certain parameters under which it doesn't work, or parameters under which you won't use it at all. So this is common in medicine and not just unique to AI.
What I love about when you're saying we is you're speaking we as a physician now, not we as a federal policy person. So I love that.
That's right.
Let's pivot a little bit to information blocking. Dr. Keane, you've made some statements about information blocking and the consequences for organizations that restrict data access. As enforcement ramps up, what message do you want to send to organizations that might still be holding back due to what they claim are technical limitations, legal or business concerns?
Well, we work from the assumption that everybody in the market wants to be a good actor. And so if people come to us and say, look, there are technical or legal considerations that are preventing us from sharing information in the way the Cures Act requires, we're willing to work with these folks to say, well, let's get a clarification on what the rules state. Let's see what we can do about the technology being more interoperable. For the most part, the complaints we hear are not of that flavor. And we have a number of enforcement mechanisms at our disposal. The first and most immediate is that we can send out a notice of potential nonconformity. If you're certified under our Health IT certification program, you are not allowed to information block. And if we get a complaint that you're information blocking, we send out a notice and say, hey, this is what we've heard. Can you tell us what's going on? And people get an opportunity to respond and say, you know what, we are information blocking, or maybe we are, but here are the reasons why. And then we can institute a corrective action plan. And if folks comply with the corrective action plan, the problem is solved. If not, then we can consider pulling their certification, and their customers will lose the incentives that they get under the MIPS programs and under the CMS payment programs. We also have at our disposal, the Office of Inspector General can level civil monetary penalties for information blocking. And as you know, the statute was written where it's $1 million per instance, up to $1 million per instance. So in theory, if you block the data of 5,000 patients, you could have tremendous financial liability for that. OIG is actively investigating complaints of information blocking, and we're providing technical assistance. There are also state laws that prohibit anti-competitive business practices under which the information blocking statutes can be acclaimed. And so in each of these instances, there are enforcement tools. I think the overall message is that information has to flow at the direction of the patient for the benefit of the patient, so that the patient's care can be optimized and so that the transactions of the healthcare system, like treatment, payment, and operations, can all happen efficiently. There are economic incentives to silo information, but now there are regulatory incentives to not silo information. And we are laser focused in this administration on making sure that information flows.
And we find that exceptionally helpful. We close every podcast with the call to action. So starting tomorrow, if you could do anything, if there was one thing that you wanted people to do, what would that be, Dr. Keane?
Well, it depends on how big my magic wand is. I would love, as somebody who's a policymaker, I would love to see some of the bureaucratic overhang that everybody in the healthcare system has to deal with. I'd love to see as much of that disappear as possible, and we're hoping that technology makes that happen. So, for example, if prior authorization can be automated electronically, that will save about $19 billion over 10 years in administrative costs that actually happen in the healthcare system. If we can get patients' data and pricing available to them, it will make services shoppable, and it'll allow them, as we talked about earlier, to choose the lowest cost drug. But I would say my biggest priority is to get data to be liquid. Overall, we want data to flow, as I said, for the benefit of the patient, at the direction of the patient, and to support the necessary transactions in healthcare. The very first and most important pillar of ONC's activities right now is data liquidity. We really want to see data flow. And I know that you guys at Point of Care Partners, and I know that my colleagues Janice and Alix are working towards that same outcome. So I think everybody is aligned, and now we just have to make it happen.
We are. Alix, any final thoughts from you? We just have a few minutes left, but any final thoughts?
This has been a great conversation. We have so much more we could talk about, including prior authorization, but I look forward to the next opportunity and ongoing collaboration in the village, because this is a very multidimensional, complex set of opportunities, from citizens to clinicians to developers to standards world and government leaders at the state, local, and federal level. So come join us. Your voice matters.
Janice, we just have a few minutes, but any final thoughts from you?
Yeah, I think we don't have a shortage of frameworks, policies, or even technical specifications. What slows us down is fragmented adoption and the tendency to optimize locally instead of aligning collectively. And I would echo what Alix said and Tom. We are working on this. That's why FAST has gotten so involved in the CMS Aligned Networks initiative with the identity and other working groups, because it's educating the vocabulary, it's bringing the group together and letting them know what work we've already done with efforts like FAST, Da Vinci, Gravity, and others, and how, to your point, Tom, we can support that scalability and that awareness of having a trust foundation that people can feel comfortable about.
Dr. Keane, thank you for joining us today and sharing your perspectives on health IT policy. Alix, Janice, thank you for helping ground the conversation in what's actually happening across the industry. For our listeners, you can find this and other episodes of The Dish on Health IT wherever you get your podcasts. If you enjoyed this conversation, share it with a colleague and subscribe so you never miss an episode. And if this discussion raised questions about how policy and standards may shift the impact for your organization or where to start, please feel free to reach out. We're always happy to compare notes. Until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@pocp.com to learn more about our Interoperability Outlook subscription monitoring service.